Hi, ma'am. Good evening. Hello. Hello, ma'am.
Hello, yes, hi.
Yeah. Hi, ma'am. So I have made to the co-host, ma'am. You can share the screen and start the class, ma'am.
Okay, fine. I'm starting. Just give me 2 minutes.
Yes, ma'am.
Yeah, I'll start. Hello, all. So in this class, we're going to discuss genitourinary system, and we'll be discussing mostly case-based questions and case-based MCQs in this question, in this chapter. And I will be also telling you how to approach any case and how to arrive at a diagnosis. This is a part of our 90-day university pre-final mastery program in which rapidly revision of all topics will happen and along with quick revision of all the volatile facts along with high yield topics which can be asked in your exam. And then these are the questions which we are going to discuss. In Oracle, we have recorded classes, live classes, practical sessions, exam modules, and also hard copy books. In recorded classes, we're going to have flexible learning along with convenient revision of all the topics. Live classes have in-depth coverage along with MCQs and discussions. Express exam module has all the previous year questions compiled together so that the entire syllabus can be revised in just 20 hours. There is a one-to-one doubt clearing session along with question banks which can be customizable and they can be of variable difficulties. Practical session which simulate the original practical exam are also available. These are the subscription plans. So in today's class, what we're going to do is we're just going to discuss many cases. Okay, and then we'll tell you a few key points so that if you find those key points in the case, it will help you in getting arrive at a diagnosis and all the key points which you have to mention in the answer. So first and foremost, the most important thing to diagnose a kidney case is you have to know whether the case falls under nephritic syndrome or nephrotic syndrome. That is the first thing. You're being given a case, and to answer that case, you have to first know that is this nephritic or is this nephrotic? Okay. So if this is confusion is cleared, then most of the cases you can solve because a few conditions they come under nephritic and a few conditions they come under nephrotic. And I'll tell you another other few clues to diagnose those conditions also. So first thing you have to look for to identify if it is nephritic or nephrotic is look at the proteinuria. If they have given you in the case that the protein is more than 3 or 3.5 gram per day, then it clearly falls under nephrotic syndrome. Okay, so number one thing you have to look at is the protein. If the patient has protein more than 3.5, falls under nephrotic syndrome. Second thing you have to look for is look if the patient has hematuria or not. If the patient has hematuria, then it falls under nephritic syndrome. So number one, look at the protein more than 3.5, nephrotic syndrome. Then look at hematuria. If hematuria is there, then it is nephritic syndrome. So these two things are there. So once you have, there are other few symptoms also which can be clues. For example, if the patient has nephritic syndrome, the patient is going to have hypertension also. And if the patient has nephrotic syndrome, the patient is going to have peripheral edema. The patient is going to have edema and hypoalbuminemia in the blood. Okay, because protein has been excreted and albumin is going to be lesser in the serum. So these are other few clues you can look for. Now you have identified if the patient has nephritic syndrome or nephrotic syndrome based on these clues. Then you have to look for conditions which can be nephritic or nephrotic. Okay, I have identified now this is a case of nephritic syndrome because the patient has hematuria and protein is less than 3.5. Okay, so nephritic syndrome. What could be the other clues which you have to look for? So there are a few conditions which are associated with nephritic syndrome. For example, you have anti-GBM disease. Anti-GBM disease is associated with nephritic syndrome. So what clue can you look for if they are giving you anti-GBM disease? Anti-GBM disease usually has hematuria, which is a case which you can see in nephritic syndrome, and the patient will also have hemoptysis. So hemoptysis plus hematuria, if they have given you in the question, then the answer would likely be anti-GBM disease. Okay, because anti-GBM disease you will have hemoptysis as well as hematuria. Okay, and the second case which is most commonly asked is post-streptococcal glomerulonephritis. As the name says, it is very easy, post-streptococcal. So you will have a history of pharyngitis in these patients. Okay, so this is one clue which you can identify if the case is PSN. Of course, hematuria, of course, nephritic, so not more than 3.5 protein. So these things are definitely there. Other than that, you will have a history of pharyngitis also. Again, there are other, these two are the major things which you have to remember. Okay, and then there are a few nephrotic cases which they can ask you. So first most important case which they commonly ask is minimal change disease. Okay, minimal change disease is going to be one case where you will have normal light microscopic findings. Normal light microscopy. So you know it is nephrotic with normal light microscopy. Nephrotic with normal light microscopy in a child, always think of minimal change disease. Okay. And then another condition which you can be asked is FSGS. Okay, FSGS can also be asked. FSGS usually have food process effacement and it can also have crescents. Okay, so these are a few things which you have to remember in nephritic and nephrotic. So we'll go ahead and discuss a few cases and then we can see if we can decode it or not. Okay, before moving on to the cases, I would like to show you a few deposits which can occur in different diseases. So number one, this one. So the above portion here, the blue one is nothing but an epithelium. This is an epithelium. Okay. And whatever this is, the red one is glomerular basement membrane. So this is the epithelium, this is the glomerular basement membrane, and then below it is the endothelium. So this is the endothelium. Okay, this is a very important image. You can remember this. And you can see there are some deposits below the epithelium here. This is the epithelium. There are some deposits below the epithelium here. So these are nothing but subepithelial deposits. Okay, these subepithelial deposits are protruding and they are making this shape. The epithelium is kind of bulging up. So this is subepithelial humps. So these are characteristic of post-streptococcal glomerulonephritis. Okay. So these are seen in post-streptococcal glomerulonephritis. And then here, number 2, we can see there are some deposits which are in between these epithelium. So these kind of deposits are seen in Hayman nephritis. These are not subepithelial, but these are somewhere intraepithelial. So in between these epithelial cells, you can see these deposits. So these are seen in Hayman nephritis. Okay. And then number 3, you can see here below the basement membrane and above the endothelium, you have some kind of deposits, right? So this is above the endothelium and below the membrane. So these are also subepithelial deposits. So, these are deposits which are above the endothelium. Okay, so these type of deposits are seen in membranoproliferative glomerulonephritis. And then here, number 4, these are the mesangial area. This is the mesangium. Inside the mesangium, you can see a few deposits over here. So these type of mesangial deposits are seen in IgA nephropathy. Okay. So these intramembranous deposits, there are another type of deposits which are present inside the membrane. This is the glomerular basement membrane, right? So you can see some deposits which are inside the membrane like this. These kind of deposits are seen in membranoproliferative glomerulonephritis type 2. Okay. So these type of deposits can also be seen. So these are the type of deposits which you have to remember. Remember subepithelial deposits below the epithelium over here, subepithelial hump-like deposits in post-streptococcal glomerulonephritis, intramembranous deposits which are also seen here, intraepithelial deposits, and then these deposits which are above the endothelium, okay, and below the membrane. So these kind of deposits are seen in membranoproliferative glomerulonephritis. You can also see intramembranous deposits which are inside the membrane. These kind of deposits are seen in membranoproliferative nephritis type 2. And then we have mesangial deposits which can be seen in IgA nephropathy. So these are the things, certain clues to crack cases. So we'll go ahead and discuss case 1. So the case 1 has mother of a 5-year-old male child complains of facial puffiness and swelling of lower limbs. So what is there here? We have edema. Okay, we're having edema here. Urine examination is positive for recruitment. 5-year-old child with edema. So what will you think of the most common cause of proteinuria in a child? It's going to be minimal change disease, correct? So you're going to be asked to diagnose the case, and what all are you going to be asked? Diagnosis, etiopathogenesis, and then urinary and biochemical characteristics. Right? Once you have diagnosed the case, minimal change disease. Now, what is the etiopathogenesis? First of all, you have to know that in minimal change disease, the light microscopic finding is normal. Okay, and there has to be something wrong, right? Proteinuria is happening. Even though light microscopy is normal, there has to be some finding which has to be there because there is some abnormality happening. So you will find it in electron microscopy. Electron microscopy is going to have effacement of food processes. Now, what are these food processes? There are food processes which are present, okay, surrounding the glomeruli, right? So these food processes, the function of these food processes is absorption of protein. Okay, so these are the areas which absorb protein in the food processes, which come out like this. But in minimal change disease, what is going to happen? There's effacement of food processes. Effacement is nothing but you don't have these areas. You will have something like this, something like this. So when this area is not there, there's going to be decrease in protein absorption. So when protein is not absorbed, it's going to get excreted throughout. It's going to be excreted out in the urine. So when it is excreted out in the urine, it is going to produce proteinuria. Okay, so that is why you have proteinuria, and that too nephrotic range proteinuria more than 3.5 grams per day. So this is what happens in minimal change disease. So now you know you have normal light microscopy, and in electron microscopy you're going to see effacement of food processes leading to protein loss in the urine. This is often idiopathic and occurs in children, but usually it can also follow certain infections and vaccinations, though it is idiopathic. So what will be the urinary findings and biochemical characteristics? So very easy. Protein is out in the urine. So what will you see? You're going to see protein in the urine. So proteinuria, number one, proteinuria. Increased protein in the urea. Now protein has gone out in the urine. So what is going to happen in the blood? The blood protein level is going to decrease. So what is the major protein which is present in the blood? It is nothing but albumin. So you're going to have hypoalbuminemia. Emia is blood. So you're going to have hypoalbuminemia. Okay. Proteinuria, hypoalbuminemia. And then hyperlipidemia. Okay, you're going to have hyperlipidemia. This you hyperlipidemia you're going to have. Okay, and then fourth thing, protein has gone in the urine. We know that when protein is the molecule, protein is that protein is what maintains the osmotic gradient inside the blood, correct? So we have blood over here and we have intravascular protein. There are lots of most common protein, intravascular protein is the albumin. So we are going to have lots of albumin. Now, this is what where the osmotic gradient inside the blood vessel is high because there is high protein content inside the blood vessel. And outside the blood vessel, that is in the tissues, for example, we do not have that much of protein content. So we have less osmotic gradient. So usually what happens, blood water flows from low, how does the water flow? It flows from, for example, there is low osmotic content here and high osmotic content. So it flows from the place where low osmotic content is there to the place where high osmotic content is there. Okay, so this is how water is going to flow. So from the tissue is going to come inside. Why? Because you have increased osmotic gradient inside the blood vessels. But if protein is lost, all protein has gone in the urine. Okay, not all, most of it. So it's going to decrease the osmotic gradient inside the blood vessels. So it's going to increase the osmotic gradient which is present inside the tissues. So you're going to have edema. What is edema? Water accumulation in the tissues is edema. So ultimately from the blood vessels, water is going to go off into the tissues. So this is what will lead to the last symptom, edema. So these are the symptoms which you have to remember it. And these are the biochemical characteristics also. So that is it for case 1. Now we'll go ahead and discuss case 2. So an 8-year-old boy has a history of puffiness of face. He has red urine following URTI. Urine shows proteinuria and hematuria. Okay, there cannot be a classic history more than this. They have given you red urine. So what does that mean? The patient has hematuria. If the patient has hematuria, what kind of syndrome is this? Nephritic or nephrotic? It is nephritic syndrome. Okay, if the patient has hematuria, it is nephritic syndrome. And they have given a history of URTI 2 weeks earlier. Okay, so what happens in post-streptococcal glomerulonephritis? After a URTI, which is usually caused by streptococcus, you're going to have glomerulonephritis. So this is a very classic condition and very classic history of post-streptococcal glomerulonephritis. So you've made the diagnosis, it is post-streptococcal glomerulonephritis, right? What is the etiopathogenesis of post-streptococcal glomerulonephritis? The etiopathogenesis is immune complex mediated deposition following streptococcal infection. So what happens in this condition is, after streptococcal infection, certain antibodies are going to be formed to counter the streptococcal infection. Okay. So in some cases, what happens? These antibodies which are formed, they roam around in the bloodstream. And these antibodies, they resemble that of the glomerular basement membrane. Okay, so in this case, it is a iso antigen scenario. So the streptococcal antigen, it resembles that of the glomerular basement membrane. Now these antibodies which has been formed against the streptococcal infection, they get confused. They get confused and then they come and attack the antigens which are in the glomerulus. Okay, so because of that, what is going to happen? This antigen come and attack here, and then what we have as a result is glomerulonephritis. So in acute condition, what is going to happen is the cellularity is going to increase inside the glomerulus. So in histopathology, we can see increased cellularity. And because this is an acute condition, we will have neutrophilic infiltration. So in histopathology, you're going to see increased cellularity and increased neutrophilic infiltration. Okay. So this is what you're going to see. In urine analysis, we have already discussed, we're going to have RBCs in the blood, hematuria, and increased protein. Not nephrotic range, but yes, increased proteinuria is going to be there. Also, increased ASO titers. And ASO is nothing but anti-streptolysin. O titers is we'll read more about this in micro. So this is a protein which you can identify in cases of streptococcal infection. And then C3 complement levels. These levels are actually decreased. Okay? We will see decreased complement levels. We will see decreased complement levels in this condition. Why decreased complement levels? Because antibodies are being produced. Right? What does antibody do ultimately? We know that antibody, IgG antibody, can activate complement. Okay, activate complement. So what is the major part of complement? Complement C3b is the major part of classical complement pathway. Right? From your general pathology, C3b will again go and produce the membrane attack complex, which is C5b to 9. Right? So this is what will happen. So breaking down of C3 is the first step of our classical complement pathway. So that is what is going to happen. So if antibodies are increasing, they activate complement and they keep on breaking down C3 into C3A and C3B. So this is what happens as a first step. C3B go ahead and produce the membrane attack complex, and C3A becomes a anaphylotoxin and chemotaxin, right? So this is what happens in the complement pathway. That is why whenever antibodies are increased, it's going to activate the complement pathway and reduce the C3 levels in PSVM. So this is one. Increased ASO titers, decreased C3 complement level. Renal biopsy can be done if needed because this condition can be resolved, and if with medication this condition does not resolve, then we can go ahead and perform a renal biopsy in certain cases, not necessarily in every case. Okay, so histopathologic findings, remember hypercellularity, neutrophilic infiltration, and most important, electron microscopic findings. We just discussed subepithelial humps. Okay, subepithelial humps in post-streptococcal glomerulonephritis. All right. So next one is case 3. Case 3 is a case of a 12-year-old boy who is brought to the clinic, and he complains of swelling in his lower legs and around the eyes, which has begun a few weeks ago. His mother reports that he is feeling unusually tired and experiences frothy urine. Now remember, frothy urine means protein in the urine. Okay, protein in the urine gives a frothy appearance. Okay, there is no history of fever in this patient. Sore throat is not there. Okay, we have ruled out fever, sore throat. So post-streptococcal glomerulonephritis is unlikely. His past history is unremarkable, but he has gained significant amount of weight over the last year, which means he has edema. Okay, so he has edema, he has frothy urine, which means increased protein in the urine. He has swelling of lower legs, peripheral edema again. So all suggest to a nephrotic syndrome characteristic. This is a nephrotic syndrome. So 12-year-old boy, what would you think of first? You think of minimal change disease. But let's read more and see what they are giving. Blood pressure is a little bit elevated for age. Again, everything, edema is there. We already know proteinuria, no significant hematuria. Again, points towards nephrotic. Low serum albumin. Serum cholesterol elevated. Again, nephrotic. We saw that hyperlipidemia is there in our we saw that hyperlipidemia is there in nephrotic syndrome, slightly elevated creatinine. Now, what do we see in renal biopsy findings? We're seeing that there is segmental scarring with some glomeruli. Do we see segmental scarring with some glomeruli in minimal change disease? No. In minimal change disease, what will we see in light microscopy? We're going to see a normal light microscopy. Okay, so this is a different case. Segmental scarring in some glomeruli. That means there is scarring. Podocyte injury and food processes observed, same as minimal change disease, no immune complex deposits. Now, this is a case of focal segmental glomerulosclerosis because the one and only difference here is light microscopy is not normal. If the light microscopy findings are not given, then you would have easily diagnosed this as minimal change disease. But because light microscopy shows scarring and they've given you this, the diagnosis here changes. It is focal segmental glomerulosclerosis. Focal segmental glomerulosclerosis is characterized by segmental scarring within some glomeruli. Okay, now you can see few glomeruli showing something called as crescents. Okay, crescent is nothing but a half moon shaped structure which is actually filled with epithelial cells, macrophages, some inflammatory cells, and fibrin. So these are known as fibrocellular crescents. It has fibrous material, it has fibrin, and it has cells. So what are the components of these crescents? You will have epithelial cells in these crescents because they're formed by the epithelial cells. You will have fibrin in these crescents, and you will have macrophages in these crescents. That is immune cells, epithelial cells, and fibrin. So these are known as fibrocellular crescents, and you can see these in focal segmental glomerulosclerosis. Common cause of nephrotic syndrome in adults and increasingly recognized in children also. So you can see this in both. So nephrotic syndrome in adults, most common cause is FSGS. Also remember this could also be an MCQ. So FSGS, most common cause of nephrotic syndrome in adults. And most common cause of nephrotic syndrome in children, minimal change disease. Okay, these are some two things. How can this be caused? It can be primary as well as secondary. So in primary, you will not have any underlying disease. In secondary, you can have diseases such as even HIV infections, obesity, many other conditions can be there. So in light microscopy, you can see scarring, segmental sclerosis. You can also see crescents. And in electron microscopy, you will see podocyte injury and food process effacement. Similarly, that is the reason that we have proteinuria as we already discussed. Now, this is another case number 4. So in this case, we have a 35-year-old woman who presents with recurrent episodes of flank pain and hematuria. Okay, so this is a slightly different case. This is not a case of nephritic or nephrotic syndrome, but this is a case of congenital disease. Now we're going to discuss a few congenital diseases. Flank pain and hematuria. She reports a history of urinary tract infection. So remember, she has recurrent UTI. She has recurrent UTI. Additionally, she has also been diagnosed with multiple kidney stones. And these multiple kidney stones require lithotripsy. So, you have multiple kidney stone history and you have UTI history. Okay. Blood pressure here is normal. There is mild tenderness on the right flank. Urine analysis shows hematuria but no proteinuria. Okay. So, you can see elevated calcium levels also. This is one key feature here. IVP, which is intravenous pyelogram, reveals a brush-like or paintbrush-like pattern in the renal papillae. So this is because of consistent dilatation of the collecting ducts in both the kidneys. Ultrasound also shows multiple cysts in the medullary portion. This is a great clue. So you have multiple cysts in the medullary portion of the kidney. This is nothing but medullary sponge kidney. So remember, multiple UTIs in this case, multiple renal stones. This is a congenital disorder, which is characterized by cystic dilatation of the renal collecting ducts, often symptomatic but can present with hematuria, renal stones, urinary tract infection. Imaging shows a brush-like pattern in papillary ducts. So this is one congenital disorder and this is not inherited. This is not an inherited condition. This is a sporadic condition. Now, over to the next case. A 3-month-old infant is brought to the hospital for routine checkup. Parents report that he has been experiencing poor feeding, rapid breathing, and history of failure to thrive. The family history is unremarkable and the pregnancy was uncomplicated. On examination, the pediatrician notes that the infant has enlarged abdomen. The weight is below 5th percentile for age. Blood pressure is elevated for age. Okay, so abdomen shows palpable bilateral flank masses. So you have enlarged kidneys in this child. Serum creatinine, everything is elevated. Renal function is impaired. Proteinuria is there very slightly. So what does the ultrasound show? Shows bilateral enlarged kidneys with multiple cysts, predominantly in the collecting ducts. Okay. Here, the most important clue I would like to say is hepatic fibrosis. Whenever there is a kidney disease in a child with hepatic fibrosis, always think of autosomal recessive polycystic kidney disease. Okay, always think of autosomal recessive polycystic kidney disease because this is one of the conditions, one of the childhood conditions which is associated with hepatic fibrosis. So, kidney cysts with hepatic fibrosis in a child, always think of autosomal recessive polycystic kidney disease. So, this is autosomal recessive polycystic kidney disease. As the name says, it is autosomal recessive. It is associated with mutations in the PKHD1 This leads to cystic dilation of renal collecting ducts. Also, we saw collecting duct dilatation is there. It also has hepatic fibrosis. Clinical presentation is usually renal enlargement as we saw and then impairment of renal function. Okay, so how does this happen? The disease affects both kidneys and often the liver. In kidneys, there is cystic dilatation of the collecting duct which leads to progressive dysfunction. Liver involvement of congenital hepatic fibrosis can lead to portal hypertension over time. So the management is supportive and prognosis is variable. Now what we are going to do is we are going to see differences between a few congenital diseases and how to differentiate them. First disease we are going to see is adult polycystic kidney disease. Adult polycystic kidney disease is autosomal dominant. Always remember AD, adult polycystic kidney disease, right? AD for adult and AD for autosomal dominant, remember. Childhood is AR, autosomal recessive. Childhood polycystic kidney disease is autosomal recessive. Now what clues for autosomal dominant? First of all, it's going to be an adult. Okay, if they give you a case, it's going to be an adult case. And then again, large liver cysts, yes, but no liver fibrosis. And Berry's aneurysm. They could, in the question stem, you could actually get Berry's aneurysm. So it's very likely that you get a Berry's aneurysm along with an enlarged kidney in an adult. And possibly you can also get a family history because it's autosomal dominant, correct? What would be the clinical symptoms? Hematuria, flank pain, urinary tract infection, renal stones, and hypertension. And this can lead to end-stage renal disease. Okay. Childhood, we just discussed hepatic fibrosis, important. Okay. Medullary sponge kidney also we discussed. In the medulla, you're going to have lots of cysts. And what is the urography finding? What is the urography finding? We had brush-like pattern of the papillary ducts. Okay, so you can see in the image over here, this is the medulla and have something like this brush-like pattern of the ducts. Hematuria, yes. Urinary tract, recurrent renal stones, yes. But this is benign. Remember, medullary sponge kidney does not essentially lead to end-stage renal disease. Okay, so it does not essentially lead to end-stage renal disease. Rest of the other congenital diseases will eventually lead to end-stage renal disease. Rest of the other nephrotic syndromes will essentially lead to end-stage renal disease. Diabetic kidney will also lead to end-stage renal disease. Okay. So we have another genetic condition which is familial juvenile nephroptosis. This is an autosomal recessive condition caused by NPHS genes. Okay. So this is the corticomedullary, and you will have polyuria, growth retardation, anemia. Again, will lead to progressive renal failure, will lead to end-stage renal disease. We have a few acquired conditions like multicystic renal dysplasia, acquired renal disease, and simple cysts. So these can have variable findings and eventually will lead to end-stage renal disease. Simple cysts, as the name says, are simple, so they are benign. May not lead to end-stage renal disease. Okay, so if they ask you, give you a bunch of diseases and ask you which of these does not lead to end-stage renal disease, most probably medullary sponge kidney is a benign disease and it won't lead to end-stage renal disease. So does simple cysts, also benign disease. Now, what are the causes of end-stage kidney disease or end-stage renal disease as we saw? Okay, we already saw most of it. Most of the pediatric, most of the genetic conditions, adult polycystic kidney disease, autosomal recessive, childhood polycystic kidney disease, this one familial juvenile nephroptosis, multicystic renal dysplasias, everything can lead to end-stage kidney disease. Also, most of the nephrotic syndromes like focal segmental glomerulonephritis, PSVN, everything might lead to end-stage kidney disease. Also, most commonly, diabetic nephropathy leads to end-stage kidney disease. These two are very common, like diabetic nephropathy and hypertension. So, these can lead to end-stage renal disease. Polycystic, we already saw. FSGS, we already saw. So, what is end-stage kidney disease? The urine output becomes so low that permanent dialysis or renal transplant is going to be necessary for survival. So, that is end-stage renal disease, progressive renal damage and loss of function. Now we'll discuss a few multiple choice questions on the same topic. So first question, a 3-year-old boy presents with severe swelling around his eyes and ankles. Okay, his urine test shows significant proteinuria but no red blood cells. Which of these is the most likely diagnosis? At this point, this is going to be so easy that you will diagnose this. We only have minimal change disease here. Okay. Most common cause of nephrotic syndrome, significant proteinuria, no blood red cells, nephrotic syndrome. Most common cause of nephrotic syndrome in a child is minimal change disease. This is going to be minimal change disease. A 5-year-old girl has developed generalized edema and has high levels of protein in her urine. Okay. Which of these findings would most likely be seen in her blood tests? So she has developed generalized edema, high levels of protein in her urine. Again, the diagnosis is minimal change disease. But here the question asks which would be seen in her blood tests. Blood tests specifically. So we know that there's going to be proteinuria and because of that hypoalbuminemia. So this is what is going to be seen in the blood test. Again, very easy. Next one. An 8-year-old boy presents with swelling around the face and dark colored urine for 2 weeks. Now, we see a dark colored urine here. So, when we see a dark colored urine, what should we think of? Hematuria. We have hematuria here and we have after sore throat. So we have hematuria after sore throat. A urine analysis reveals both protein and red blood cells. On renal biopsy, what is the most likely finding? Okay. Now this is an interesting question. Podocyte effacement, do we see on a renal biopsy? We would not see unless we do an electron microscopy. Correct. Mesangial cell proliferation? No. Lipid-laden macrophages also. So we know this is the diagnosis here is post-streptococcal glomerulonephritis because there is a sore throat. And what do we see in post-streptococcal glomerulonephritis in light microscopy? We are going to see hypercellular glomeruli with neutrophilic infiltration. So this is the answer. If they ask what will you see in electron microscopy, we are going to say subepithelial. Okay. So next one, a 7-year-old child with nephrotic syndrome presents to the clinic. Which of the following features would be unexpected in this patient's presentation? So again, 7-year-old child, nephrotic syndrome, minimal change disease. Which would be unexpected, little bit twisted this question is. So what would you not see? So you will see edema, yes, you will see hyperalbuminemia, you will see hyperlipidemia. What will you not see? You will not see hematuria because it's seen in nephritic syndrome. Again, next question. A 10-year-old boy is diagnosed with FSGS and has been experiencing frequent fatigue and swelling over his lips. Which of the following is most likely associated risk factor for this patient? Now we know the patient is diagnosed with FSGS. Okay, so 10-year-old boy, usually primary, then we know that there are two types of FSGS. We have primary FSGS and secondary FSGS. Primary FSGS does not have any risk factors, and secondary FSGS may have multiple risk factors like diabetes mellitus, obesity, and even hepatitis C infection. So all of these are risk factors of FSGS. What do we see in primary FSGS? It is idiopathic and it may have food process effacement, and in light microscopy you're going to see sclerosis of segmental sclerosis of glomeruli. So this is what you can see. Now let's see the next question. A 9-year-old boy presents with facial swelling and dark colored urine. Recent step infection. At this point, you can answer this very easily. So which of the tests would most likely confirm the suspected diagnosis? Which of the tests? Serum albumin level, not going to help. Calcium urinary, not going to help. No. ASO titers will be elevated, as I said, in post-streptococcal glomerulonephritis. And you will have decreased C3 levels also, complement 3 levels also. So these two tests can help. Next, a 6-year-old girl with significant proteinuria and facial swelling has low serum albumin level and elevated cholesterol level. What other feature is she likely to have? Now, what is the diagnosis here? Significant proteinuria, facial swelling, low serum albumin, and elevated cholesterol level. What other clinical features should she have? Hematuria should she have? No. What does she have? What is the diagnosis? The diagnosis is minimal change disease, right? Proteinuria with low serum albumin and elevated cholesterol. Features of nephrotic syndrome. Leukocyturia. No. So what she will have is severe edema. Hypercalcemia also. So at this point, these questions become so easy since we have discussed so many variants of the same questions now. A 12-year-old boy is diagnosed with end-stage renal disease due to progressive damage over several years. Which underlying condition is he likely to have been contributed? So now here we know that this 12-year-old boy has a end-stage kidney disease. Okay, so this has to be a condition which is a childhood condition. We know what we know at this point is medullary sponge kidney will not lead to end-stage kidney disease. So we can easily eliminate medullary sponge kidney here. Chronic glomerulonephritis and diabetic nephropathy are conditions which this one will occur in a person who is a diabetic. Chronic glomerulonephritis can be due to multiple reasons. So in this case, the answer is polycystic kidney disease and more specifically autosomal recessive childhood polycystic kidney disease. Now the next question. A 15-year-old boy with history of kidney stones undergoes an intravenous pyelogram and shows brush-like pattern in his kidneys. We have discussed this. Which condition does he most likely have? So brush-like pattern in his kidneys we know because of medullary involvement. We have a brush-like pattern in the kidney, which is seen in medullary sponge kidney. Next one, a 4-year-old boy presents with severe swelling and lethargy. His urine is positive for protein but does not show any signs of blood. Which histologic feature is seen? So, minimal change in glomeruli. More specifically, we would see a normal light biopsy, normal light microscope. Okay. That is why the name itself is minimal change, because there is not much change in light microscopy. In electron microscopy, you would say food process effacement. So that is it for today's lecture. Thank you so much. See you in the next genitourinary lectures. Thank you.